I'm going to welcome everybody back. And I think that we have one of our speakers flying the farthest and giving us one of the most difficult talks and the hot topic of our osteoporosis treatment world. So I'm honored to introduce Dr. Bente Langdahl, and she's going to speak about management of patients discontinuing or transitioning off of DMAB, denosumab, or Prolia, as you all know. Welcome, Bente.
Thank you. Thank you very much for the kind introduction. And also thank you very much for the invitation to come here. This is my first time at this bone meeting, and it's also my first time in Santa Fe. And I can tell you that this is clearly very, very different from Denmark. So Denmark has now, along with the other Scandinavian countries, become a place where you can go for cool-cation. Because southern parts of Europe are now so hot that it's difficult for many people to go there on vacation. So clearly difficult, clearly different, and very much appreciated. So, and probably one of the main reasons why I'm here is, as I listed at the bottom of this slide, that I have been invited as an external advisor and contributor to one of the projects of the Western Osteoporosis Alliance, a project that is ongoing, where the aim is to produce a manuscript on how to discontinue denosumab in clinical practice. So we're working on that, and hopefully you will see a manuscript or a publication on that in the not too distant future. So first of all, here are my disclosures. So this is a little bit about of the agenda, which I hope to cover in the next 40 minutes or thereabouts. So there's plenty of time for discussion and questions. So first of all, I'll say a little bit about DMAB, because my main interest in discontinuing DMAB is actually because I think DMAB is a really, really good treatment option for postmenopausal osteoporosis and also osteoporosis in men. So I want to highlight that first. And then I'll go into discussion about how to discontinue the ECTS recommendations and some of our own clinical experience. And if time allows, I'll also show you a little bit of data on men who have been treated with DMAB during anti-testosterone treatment during prostate cancer treatment. So first, let's have a look at the osteoporosis treatments we have available. We have now heard about the anabolic treatment, so this will focus on anti-resorptives. And so this is an illustration I picked from a review paper by Ian Reid, published now almost 10 years ago, but still it's a good paper. I can recommend it. But this looks at the anti-fracture efficacy of the available treatments within the first 2 to 3 years. And you can clearly see that there's a very similar anti-resorptive effect of the bisphosphonates and denosumab for non-vertebral fractures and also for hip fractures, 20% approximately for non-vertebral and 40% for hip fractures. So are there no differences between the anti-resorptive treatments? When you look at the changes in, this is total hip BMD over time, you can clearly see that the changes over the first years are quite similar. There's an increase with both bisphosphonates and denosumab. But you can also appreciate what I'm sure you've seen in many of your patients, that if you continue bisphosphonate, there's a stabilization of total hip BMD. It very rarely increases further. Whereas that is completely different with denosumab. There seems to be a continuing increase in bone mineral density. And that was, of course, also seen. This is data from the pivotal fracture trial that was extended for up to 10 years, where you can clearly see that a very prominent increase in bone mineral density here at the lumbar spine, and how that's accompanied by a reduction in vertebral fractures that stays at a very low level throughout the 10 years of follow-up. And when we look at the hip, we see a similar pattern, continuing increase in bone mineral density, and also a suppression of fracture risk here at non-vertebral fractures. There's an interesting observation that we don't know too much about, but you can see if you look closely at the see if I can use the mouse here. If you, So what should I do? So mine says session closed. Can I do something about it? Okay, we're trying to connect, I think, to the outside world. Oh, sorry. Anyway, what I wanted, I can just tell you why we're working on this. It looks from the FREEDOM trial that there is a reduction of 20% in non-vertebral fractures within the first 3 years of the study. I won't touch the mouse anymore. So, but it seems to, after the first 3 years, there seems to be a further reduction in non-vertebral fractures. Of course, there's no placebo group any further, so that makes it difficult. But you can also see, if you look at the red columns, that there seem, which are the ones shifting from placebo to active treatment, that there seems to be a further, there seems to be a further suppression of non-vertebral fractures after the first 3 years. So it takes longer time to prevent non-vertebral fractures than it does to prevent vertebral fractures. So now this is not working. Yeah, I think I can move the slides again. So last year, together with Serge Ferrari, we published a paper where it's very much like a speculation on the effects of denosumab and also on discontinuation, which I'll come back to. But here we speculate, why do we see that continuing increase in bone mineral density with long-term denosumab treatment? And we try to contrast it with the bisphosphonates, which are in the upper panel, and denosumab in the lower panel. So both drugs initially fill out the remodeling space. So that's where we see the rapid increase in bone mineral density in the beginning. And then there will be a secondary mineralization of all of these filled out resorption lacunae. But what then happens in the more long term, we speculate that could be either because denosumab actually allows modeling based bone formation, but it could also have to do with some interaction with muscle, and it could also have to do with cathepsin K, which is also a very important signal for bone resorption. So these were speculations about why we see that continued increase in bone mineral density. So how can we assess the long-term effects and benefits of denosumab and risks as well? We know there are 2 risks long-term, atypical femur fractures and osteonecrosis of the jaw that we need to take into account in the individual patient. So this illustration is based on a virtual twin model, trying to extend the data obtained with the placebo group into a 10-year frame. And here you can see with the gray columns, the expected number of fractures if patients had been continued on placebo for up to 10 years, compared with fracture risk in the patients treated with DMAP, which is clearly a reduction of all type of fractures. And there were very few in the up to 10-year treatment with denosumab, very few cases of AFF and osteonecrosis of the jaw, which seems to indicate that even in long-term treatment, and in my mind, also beyond 10 years, if the patient is still at high risk of fracture, there is still a positive benefit-risk ratio. The final thing I wanted to mention, and we'll hear much more about that tomorrow when we're going to talk about treat to target or a targeted directed treatment, is that based on a post-hoc analysis from the FREEDOM trial, which is illustrated here, we can clearly see as we improve bone mineral density to a T-score of -1.5 or -1, this is at the hip, there seems to be a flattening of the reduction in new non-vertebral fractures. And you can see that's the same if you're above or below 75 years of age, but you can see it's highly influenced by having a prior fracture. So that kind of indicates that we need to have treatments that can restore BMD to a certain level, and we'll hear much more about that tomorrow. The other thing that we'll hear more about tomorrow is the SAPR FNIH Bone Quality Project that has clearly demonstrated that the bigger the increase in bone mineral density, the bigger your reduction in fracture risk will be. So that's another argument for why we need treatments that can really improve BMD to a great extent, also in the ones with very low bone mass. So that's my thoughts about why denosumab is a very important treatment. But of course, we also have to figure out how we can discontinue denosumab if there are reasons to do so. We've known from very early days, this is a paper that is now 13 years, it's 13 years since it was published, showing that if you discontinue denosumab after 2 years of treatment, there's a very, very rapid decline of BMD at the spine, but also at the hip. At the hip, it actually goes below the baseline BMD. And they also measured bone turnover markers here, and you can see that the discontinuation of denosumab is associated with that very prominent increase in CTX already, or even after only 2 years of treatment. So there's no doubt that there is a rebound or an overshoot activation of CTX or bone turnover when you discontinue. Again, based on the FREEDOM trial, post-hoc analysis of vertebral fractures and multiple vertebral fractures occurring in patients who discontinued treatment during that trial were performed. And here you can see in red the risk of vertebral fractures and multiple vertebral fractures during the course of the trial. So if you're on placebo, you had a risk of 7 per 100 patient years. And whereas that was, as we know, now very prominently reduced with denosumab. And so here you can see the risk of vertebral fractures and multiple vertebral fractures in the patients who discontinued either denosumab or placebo. So for vertebral fractures, it looked like the risk is going back to what you see in untreated patients. But when you look at the multiple vertebral fractures, there is a more prominent increase than what you see with the patients discontinuing placebo. So something to care about. So this was the first analysis where all patients, irrespective of whether they had post-discontinuation X-rays, were included. So later on, Felicia Kosman and co-workers, they did a study where they only included the patients who had post-discontinuation X-rays to be certain that no fractures were missed just because no X-rays were performed. They were quite similar to the overall group, as you would expect. And here you can see, again, the exposure-adjusted rate of fractures in women discontinuing placebo in blue and discontinuing DMAP in red. And again, they found the same. There was an increased risk of multiple vertebral fractures and also especially more than 4 vertebral fractures. They were also, in that additional analysis, able to look at the impact of the duration of DMAP treatment. So here in the white bars are the placebo, the women who discontinued placebo. In the light gray bar, or in the gray bars, are the women who discontinued DMAP after less than 3 years, whereas the black are the ones who discontinued after more than 3 years. And again, you can clearly see that the problem, especially with multiple vertebral fractures and more than 4 vertebral fractures, are very prominent in the ones who've been treated for more than 3 years. They were also able to show that there are things we need to look out for if we want to predict which patients are at the highest risk. So especially patients who've had a prior vertebral fractures are the ones where we should be very careful when discontinuing denosumab. They have a high risk. And the longer they have been on treatment and off treatment also increases the risk. And the bone loss, which kind of goes with both of the above, is also associated with an increased risk. So what can we then do about it? So this was, of course, already known before the FREEDOM trial was ended, but there was no formal follow-up of the FREEDOM trial participants. But this is an extended case report, I would call it, from Ian Reid's group in New Zealand, where they decided, okay, we have these women, they've been on DMAP for 7 years. They were the prior placebo group, so they'd had DMAP for 7 years. And then they decided, let's give them 1 infusion of SOL when they discontinue DMAP. So here's the outcome. You can see there was a loss of BMD when they measured 2 years later, both at the spine, but most prominently at the hip. And that was actually what what was available of data of how to counteract this overshoot reaction when we planned our study. Because when you hear what we did, you think, my God, why couldn't they figure out that that wouldn't be good enough? But the discussion at that point was that maybe treating 6 months after the last DMAP is too early. Maybe we need to allow for some bone remodeling to start so that there's a more uptake of zoledronate on bone surfaces. So the whole idea of having some bone turnover to facilitate the effect of zoledronate is kind of the main basis of why we designed the study as we did. So as you can see, first of all, we wanted to investigate the timing. So we had a 6 months groups which had zoledronate, 5 milligrams IV, right 6 months after their last DMAP. Then we had a 9 months group where we were trying that, should we maybe delay it a little bit? And then we had an observation group, which was not truly an observation group, but it was the infusion was delayed until 12 months after the last DMAP, unless they had high levels of CTX. So we measured CTX every month in the delayed infusion groups to not overlook something important here. But our cutoff was really, really high. The cutoff of CTX was 1.26, which is 50% above the postmenopausal reference range in Denmark. So now we know that that was way too high. But what did we know then? So here you can see it was a small study, so there are no fracture data, 20 individuals in each group. You can also appreciate that approximately 50% had a prior fracture, and they had almost all had a short duration treatment with alendronate, because that's the reimbursement criteria for DMAP in Denmark, that you either can't tolerate or have diseases that are contraindicated for contraindications for alendronate. But they had been treated for an average 4.6 years with DMAP. So not short term, but relatively long term. And they all had BMD T-scores in the osteopenic range. So here you can see, this is a quite busy slide, but just look at the colors. So all the orange boxes indicate number of patients who were treated due to BMD loss, which was more than 5%. Or all the purple boxes indicate patients that were treated due to CTX above the 1.26 criteria line. So it turned out to be way more busy than we thought. But anyway, here you can see the outcome. All of the groups lost BMD. This is at the lumbar spine. So on average, 4.5%, despite of what we did. You can appreciate, I think, that the blue line, which is the early treatment group, had a slower loss of BMD, which we still think is an advantage if we want to prevent especially vertebral fractures. And here you can see the changes at the hip. It's very similar, very rapid decrease in the ones with the delayed treatment, and a slightly slower loss rate in the ones that were treated early on. And here is the explanation, changes in CTX. Again, if you first look at the blue line, you can see that we were actually able to further suppress CTX in the ones treated immediately or after 6 months with DMAP, but it just escaped again. And whereas you can see that the 2 delayed group had very rapid, very prominent increases in CTX. They could be suppressed when they were treated, but it was high for too long a time. We also saw in our study that longer duration of therapy with denosumab was associated with higher CTX levels at baseline. That was actually not a surprise, because that was also seen in the FREEDOM trial, that the longer the treatment duration, the more escape of CTX was seen every pre-administration time point. But we could also see that that has an importance, because we could see that the changes in total hip BMD from baseline to 24 months was actually associated with that CTX baseline value. So the ones that had higher CTX at baseline were also the ones that lost more BMD. So that's another marker you can take into account. If CTX is not thoroughly suppressed when you try to discontinue, then there is a higher risk of BMD loss. We have also further tried to understand what is going on, because maybe that's the key to figuring out how to deal with this. So we tried to measure rank ligand, OPG, TRAP5B, CTX, and P1NP. And I'll just quickly show you the time. So the samples that I've included here are all samples that were taking pre-soletronate treatment. So it was either 6 months for the 6 months group and 9 months for the 9 months group and so on. But we can see that there is this increase of rank ligand. There's a very high level of rank ligand. The first things that happened is an increase in TRAP5B, and then that's followed by an increase in CTX, and later on by P1NP. And then you can see quite early on, there seems to be the rank ligand available seems to be used up for all this initiation of resorption. But of course, TRAP and CTX, they stay high because they are an image of what is happening. And then there's this little bit delayed increase in P1NP. But what you maybe are also able to appreciate here is that we saw absolutely no change in OPG. So this is OPG measured in serum, and there are several sources of OPG. It's not only bone, so that's something we need to take into account. But it is a little bit troublesome that there's no increase in OPG when you see this very high level of resorption going on. So what have others found, and what can we learn from that? So this is data from a relatively large observational study performed in Switzerland, where they included almost 800 cases. And here you can just see the number of vertebral fractures and non-vertebral fractures before DMAP, during DMAP, and after DMAP. And you can clearly see the problem are the number of vertebral fractures. Interestingly, they also recorded the time of these vertebral fractures. And so here at the x-axis, you can see the number of months after discontinuation of DMAP. And you can clearly see that most of these vertebral fractures, they occur within that 1 year after discontinuation. So that's clearly the time where we have to pay special attention to these patients to prevent these fractures. So this was an observational study, so there were no guidance of how to treat, but you could very much appreciate that the full line is the risk of vertebral fractures, or it's the Kaplan-Meier of the vertebral fracture-free survival in the non-treated patients compared to the ones who had bisphosphonates before DMAP, which is the dotted line, compared to the ones who had bisphosphonates afterwards, where there were hardly any vertebral fractures. But again, the window is these 12 months after discontinuation of DMAP. So that's where we have to pay special attention to our patients. Other studies, what can we learn from that? So the DAP study, which was actually a patient's preference study, trying to figure out whether patients would prefer alendronate or over DMAP. But in that study, the patients were either randomized to 1 year of DMAP followed by alendronate, or the other way around. And here you can clearly see that if it's only 1 year of DMAP, which is where the blue columns at the bottom, you can see that if you only treat for 1 year with DMAP, you can maintain the BMD at the lumbar spine and almost maintain it at the total hip by proceeding with 1 year of alendronate. So if it's only a short duration of DMAP treatment, alendronate might be able to do the trick. We have tried it in one patient, not at our goodwill, but this was a very, I would say, stubborn patient who thought she had figured out what this was all about. So when we met her, she was 79 years old. She had been diagnosed with osteoporosis 7 years before, and were treated for these 7 years with DMAP, and had responded quite well, but still she had low T-scores, minus 3.2 at both the lumbar spine and total hip. But she's made the decision, I'm not going to take any more drugs that can be injected into my body. So we were kind of stuck with alendronate, and here you can see the increases in CTX and P1 and P over the month after discontinuing. So that was terrible looking at it. But she was stubborn; she didn't want anything else. But then when we saw the very prominent loss in especially total hip BMD after 1 year, she agreed to go on SOL. So we treated her for SOL for 3 years. But of course, the most of the high turnover had already she had suffered that already. So that was not, I cannot advise all alendronate in patients who've been on treatment with DMAP for a very long time. It doesn't really work. So anyway, there's been another recent study from Ramchand and colleagues where they looked at 1 year of DMAP and could you follow up with raloxifene or alendronate, and how would that work? That is recently published. So it was 51 women who had osteoporosis or osteopenia and a fracture or high fracture risk. And here is the outcome. So you can see during the first 12 months where they were all on DMAP, there were prominent decreases in CTX and also P1 and P. And during the following 12 months where they were either randomized to raloxifene in blue or alendronate in red, you can see that alendronate was able to maintain the suppression of CTX and P1 and P, similar to what you saw from the DAPS study, but raloxifene is not able to do the same thing even after only 1 year of DMAP. And that also, then not surprisingly, what you can see is that alendronate was able to maintain the BMD achieved, or the increases in BMD achieved during DMAP at the spine and the hip, whereas raloxifene was not able to do that. So raloxifene is probably also not the drug of choice here. So when we worked on the ECTS precision paper, we tried to put all of that together, the studies that were available at that time. And there were some, as you can see in the first column, there was some that had short duration of DMAP, and there was some that had very long duration of DMAP. And in all of these studies, the patients were treated with either alendronate or zoledronate. And you can see the BMD changes at the lumbar spine, or preferably the total hip. And you can see that there is a clear correlation between duration of DMAP and the bone loss, irrespective of the bisphosphonate treatment. So again, how can we understand what is going on? And you can say, is this important to understand? I think it's important to try to understand what is going on if we want to prevent this bone loss better in these patients. So we put forward some theories in the review I wrote together with Serge Ferrari. And here you can see, so the most accepted idea is that this is about a synchronized activation and differentiation of osteoclast. So in the normal condition, we have pre-osteoclast, and if we believe in osteoclast recycling, which has been demonstrated in rodents, we also have those. And then when we have rank ligand, we activate the osteoclast. If we treat with DMAP, of course, that will inhibit rank ligand, and there will be no osteoclast activated. And then when we take DMAP away, there will be a lot of precursors lined up or osteomorphs also. And then if there's no inhibition to rank ligand, we will have a lot of osteoclasts generated. The other theory, as I alluded to, is the lack of OPG. We have shown it, and it has also been shown in some rodent studies that there seems to be this lack of OPG. So normally there is this counter-regulation of OPG and that inhibits rank ligand. So that is the control of the osteoclast recruitment. So if we treat with DMAP, there will be no osteoclast. The osteoclast will not communicate with the osteoblast, and there will therefore be no OPG production. But what then happens if we take away DMAP? There will be a lot of rank ligand, there will be a lot of osteoclast, but that activation of the osteoblast, and especially the activation of the osteoblast's ability to produce OPG, seems to be significantly delayed, and that could be part of the problem. So there's no intrinsic inhibitor of this process. And our final thought on this could be that this could be driven by osteocyte repair, or osteocyte-driven repair of microdamage, I should say. So we know that there is an accumulation of microdamage in the bone all the time, and that is one of the signals that lead to rank ligand production under normal situation. And then, of course, when we treat with DMAP, we block that signal. And again, then if we accumulate maybe even microdamage during years of DMAP, then there will, of course, be a lot of signaling rank ligand coming from there. The final suggestion we put forward is that this could have to do with the mechanostat. So the green line represents the normal way we think of the mechanostat. So we have a stable window. If we practice, if we gain weight and so on, that will be a loading of the skeleton that will lead to an increase in bone mass. But if we unload the skeleton, either because we become inactive or because we lose body weight, there will be a decline. With DMAP treatment, we kind of push that line a little bit up, as indicated here by the red line. There's still an interaction with physical activity. You can still improve your BMD or your bone mass by physical activity if you're on DMAP. But you can lose weight or you can stop being physical active without really losing bone if you're on DMAP because your resorption is completely blocked. However, if you discontinue DMAP and you have lost weight during the treatment period with DMAP, that could lead or that could be part of the cause for the rapid bone decline. So that's a little bit about the mechanism and about what we can achieve with bisphosphonates. But could there be other ways that we could deal with this? So I'm aware of two publications that present data on DMAP discontinuation. So the first is what you could call maybe an extended case series. 13 postmenopausal women, 68 or 69 years on average, who've been treated with DMAP for a mean of 45 months. And the protocol is that then they will gradually reduce, they will give them at month 0, they will give them 60 milligrams of DMAP, then they will reduce to 30, then they will reduce to 15, and then they will discontinue. So here is the outcome. So here look at BMD at the lumbar spine and at the hip. So T3, or I should say maybe start with T2, is 6 months after the last low-dose DMAP injection, and T3 is 12 months. So that's when they are clearly discontinued. And you can see the 15 milligrams in these patients seems to be able to maintain BMD. There's no further increase, but it's maintained, whereas there is a decrease after the discontinuation. And the same goes for the hip side. So they kind of state in this paper that this maybe could be a way because the loss of BMD is not too prominent. What I'm worried about is if you look at the individual data of these 13 women. So here in blue, that would be the CTX 6 months after the last lowest dose DMAP injection, pretty much under control. But then look at the red bars, which indicate CTX a further 6 months down the road. So, and you can also below the individual columns, you can see the loss of BMD. So some of the ones who had very high increases in CTX, they actually lost 9 or more than 9% BMD. So there's still a highly variable response to this regimen between individuals. And another concern, of course, is how can we do this? Because DMAP only comes in syringes of 60 milligrams. But it's an interesting experiment. There's another study which is, I don't know if it's ongoing, but the final outcome has not been published yet. So that's from Malaya Khan, where they took women who had been treated for more than 1 year with DMAP on average 30 months. So that's 2.5 years. And then they treated them with DMAP 60 milligrams every 6 months for a year. Or that was the year before they entered into the trial. And then they treated them with 30 milligrams every 6 months for 2 years. And this is a very busy, but just, I already mentioned that, but just to mention that a very high percentage of these women has been previously treated with bisphosphonate. And they had quite decent BMD with T-scores in the osteopenic range at all the sites, as you can see here. So these were clearly the women where you would consider discontinuation of treatment. So here you see the year one results, where at the lumbar spine, there's a further increase in BMD, whereas at the hip sites and the forearm, there's stable BMD during this first year of reduced dosing with 30 milligrams. And it's similar during the second year. Stabilization of BMD or further increase of BMD at the spine, and stable BMD at the hip. So of course, the interesting thing is to see what they decided to do after these 2 years. Did they decide to give a bisphosphonate or, but we're waiting for that publication to come out. So, so that's a little bit about the evidence that is out there. So now I'll turn to the ECTS recommendations that was published in two different papers. So first we said, thinking about this, maybe a young patient with low risk of fracture and maybe not too low BMD, denosumab treatment is probably not what we would recommend. And then if you're treated with denosumab for a short period of time, and we define that as up to 2.5 years, you might be able to get away with all bisphosphonates for 12 to 24 months. But we would recommend that if you do that, that you monitor bone turnover markers and BMD if that's something you can do. You could, of course, also go directly to zoledronate for these patients. We think the difficult group would be the ones who've been treated for a longer period of time, more than 2.5 years. And so first of all, we think there can be very good reasons for continue. And the compromise here was for up to 10 years. I don't think there are any data out there suggesting that it couldn't be correct to treat for longer if there's still a high risk of fracture. But that would probably have to be an individualized based decision. But otherwise, if you want to discontinue after a long time, we recommend to shift to zoledronate, and we would recommend to treat early. So that would be after six months after the last DMAP. And then we would follow with bone turnover markers 3 and 6 months thereafter. And we would repeat the infusion of zoledronate if there's increased bone turnover markers. But if you're not able to measure bone turnover markers, we recommend to at least give 2 infusions of SOL 6 months apart in these patients. So what if these patients who are discontinuing denosumab occur or suffers of a T-bone fracture? What can you do then? There are some few studies, mostly case reports, indicating that we probably shouldn't do vertebroplasty or shift directly to therapeutide. That has been associated with further increases in fractures or further fractures. So one way to deal with this is to reinstall denosumab. You could also treat with IV SOL. And you could consider, if you wanted to shift to teriparatide, to use it as an add-on. I know that's outside of the label, but if you could, that could be a way to give an anabolic treatment to this patient. I have a few slides on the men with prostate cancer, but I think we should probably allow some time for questions and discussions, and I can share further slides if we want to.
Thank you. Thank you all. We have some great questions. I'm going to start with the mic. And Kelly, can you introduce yourself?
Kelly Crone, University of Arizona, Phoenix. You showed us very nicely the longer the duration of treatment with denosumab, the higher the risk for bone loss. Do you have much comments on those patients who receive the oncology doses? I worked in orthopedics, so most of the patients that I stopped DMAB in were people who had atypical femur fractures, but they were receiving oncology doses. My experience was they seemed to really lose fast. So, but I got to stop the anti-resorptive because they just had an atypical femur fracture. So thoughts, and I hope ECTS would address this. and stopping DMAB in the setting of an atypical femur fracture, either the osteoporosis or the oncology dose?
Yeah, so we didn't specifically address the oncology doses, but since this is probably dose dependent, and so I expect that I don't have a lot of experience with oncology doses, but I would expect that it would be even more prominent there. What we recommend with respect to atypical femur fractures is actually not to discontinue treatment. And that is because if you put in the needle, then it will heal the fracture, even despite continuing DMAB in most cases. You might have cases where that's not true. But what we suggest is that you could, if that's a possibility, you could add teriparatide to these patients. But we think that the risk of discontinuing DMAB and suffering vertebral fractures is certainly something to take into account. And you could say, could I then shift the patient to SOL? You might be able to do that, but the risk of SOL and DMAB on atypical femur fractures is kind of the same. So I don't see immediately the benefit of doing that, but there may be individual things to consider.
So I agree, fractures generally heal in the setting of treating with denosumab for osteoporosis doses. But my little old lady just had an atypical femur fracture and she was on Prolia and she doesn't want to take it anymore.
No, but sometimes when you discuss with the patient that there is a very high risk of this fracture, which of course is not something we want, but it can, you can put in the pin and it will heal. But if she has 5 vertebral fractures after discontinuing Prolia or Exgiva, whatever she had, that's something that is not easily healed.
Thank you. Before you ask your question, McCall, I want to ask a remote question. Did you imply that the acute phase reaction with Zold, which we know is about 10 to 20% after the first and maybe only 4 to 5% with subsequents, is more after extended DMAB? And can you talk about that?
It's way more. It's way above 60 in all the publications that report on it. So we are now trying to test out. So routinely we give them paracetamol, but to prevent that, but that's not good enough in all of them. And somebody recommends to give glucocorticoids for a few days. And there's also been other things going on, but it's clearly something, and it's very common after long-term DMAB.
Thank you. Make sure everybody remotely is muted so we don't have an echo. And McCall, do you want to introduce yourself again?
Thanks. Hi, McCall Rothman, University of Colorado. Thank you so much for this data and your work on this. I think it's one of the major clinical conundrums that a lot of us are dealing with in practice. To kind of put your data together with the first talk that we heard, is it possible that we should be moving towards denosumab as thinking of it as a shorter term treatment in our armamentarium, where we're using an osteoanabolic, we're using it for a couple of years, we're following up with, alendronate or zoledronate, and then we're kind of reassessing and recycling. And maybe this idea, when it first came out that it was going to be this long-term medication, should we be just revisiting that and using it, in our high-risk people, getting those gains, but maybe just trying to quit while we can, earlier in the course?
Yeah, I think that's an excellent point. I think we have to remember that this has to be individualized, and it depends on the age and it depends on the severity of the disease. And we also have to recognize that, anabolic treatment is not available everywhere in the world and will probably not be that for the close future. So I think the idea, if you have that, to start with anabolic and then a short course of anti-resorptive, that be DMAB or that be a bisphosphonate, and then you can build on with another anabolic treatment. I think that's the way to go. If you have patients that can cope with that more intensive regimen, and then on the other side, we have a lot of elderly, frail patients where I think we should just continue DMAB and not worry too much about too many other things and discontinuing and so on. So I think it needs to be more individualized instead of just one thing fits everybody.
Thanks.
Thank you. And another remote question. We haven't said the word DMAB for life or Prolia for life, but I think a lot of us agree with that. And whether a patient would switch to Romo after DMAB, you mentioned that a little bit. Can you talk about that a little bit more? Robert Feldman asked.
Yeah, no, that's an excellent question, and we're waiting for evidence of what is the right thing to do. So we have a little bit of evidence from the ROMO phase 2 trial, where patients were in the course of that trial were treated for 1 year with demo and then shifted to ROMO, but that was only 20 patients. And what we saw was that ROMO was not completely able to stop the increase in CTX. But BMD was maintained at the hip and increased a little bit further at the lumbar spine. So I think you can do it after a short time, DMAP. I'm not really confident that that's the best way of using this combination or this sequence, but we definitely just need more data.
Thank you. And go ahead, Seth, can you introduce yourself?
Yeah, I see two
Can you
different,
introduce yourself, Seth?
I'm sorry,
Introduce yourself, please.
Seth Corin. I'm a orthopedist who does bone and osteoporosis. I see two types of discontinuation of DMAP. One is the patient just decides they don't want to do it, or their oral surgeon who's doing their implant said, oh, I won't touch you if you're on DMAP. And so they go off the DMAP, they come in, they have multiple fractures. I have found that putting on Evenity is the best way to prevent the fractures. I don't have all your data, but I found that that's a very effective way to do it. The other thing that Kelly was talking about is atypical femur fractures. They have a fracture. I agree that you could probably keep them on that, but many of them have the opposite side lesion. So you're either going to stop that or you're going to do a prophylactic nailing. So I'm not sure that keeping them on that, and as opposed to stopping the DNAB and putting them on an anabolic, is not a better way to do it.
I agree. In the clinic, it's not as easy, and you have to make decisions. And I look forward to seeing your data on the transition to Evenity. That's going to be great. So hopefully you share it with us at some point. With respect to the atypical femur fractures, I think the combination with teriparatide could be another way to go. I would just not like to discontinue an anti-resorptive in these patients.
Thank you. And please try to keep your questions and comments shorter. I appreciate that. Microphone here.
Hi, thank you for that talk. I'm Neera Medici from Albany Medical Center. I just wanted a clarification. In the beginning of your slide, you showed data about vertebral fractures after denosumab discontinuation. Was that despite being given Zol?
No, from the Freedom trial, these patients were left untreated.
Okay.
So that's what happens if you don't treat them.
But with all the CTX data you showed, did it correlate with fractures as well?
Yeah. So the higher the CTX, the higher the risk of fracture. Yeah.
And one of the remote questions asked, is there any way to predict the level of osteomorphs? And can you explain a little bit how that relates to the increased OPG? I know that's different, but those are two theories.
Yeah, so first of all, we don't know about the osteomorphs in human beings. So far, it's only something that has been shown in rodents. We are now doing a study where we're taking bone marrow samples, and we will investigate together with Michelle McDonald if there are any osteomorphs in human bone. So we'll find out, but for the time being, we don't know. But of course, if they are there, they are an additional pool of kind of pre-osteoclast and can be rapidly recruited into osteoclasts. So that's the worry if they line up. We're not really sure about the lack of OPG, if it's because the lining cells are still inhibited, or if it's because it takes too long to recruit more osteoblasts, or whatever is kind of causing that delay with OPG. So in the human samples, we have only measured it in serum. It could be higher in bone marrow. We will investigate that in another trial. But yeah, there's still a lot of unknowns here.
Thank you. And microphone here.
Hi, Bita Zahedi, endocrinologist from Mass General. With regards to patients that are getting DMAP because of CKD, and CTX wouldn't be a good marker since that would be altered based on the renal dysfunction, are there any data as far as using other biomarkers to monitor them post-DMAP discontinuation?
There's not a lot of published data as far as I'm aware, but you can use TRAP 5B if that's something you can order, because that's not affected to the same extent by renal function.
Thank you. We have a couple questions online about adding teriparatide or Forteo to DMAP. Can you
Okay,
mention
sorry,
a little
I'm in
bit
a
more
board
about
meeting
that
and
and
I'm
how we
trying
would
to
do that?
focus
Yeah,
on.
so I think so we don't have a lot of data, but we do have some data from the data switch trial, where the combination of DMAP and teriparatide seemed to be quite effective in these women who, of course, most of them were treatment naive, and some of them, and there are lots of things that makes them different from maybe patients who have been on DMAP for a long period of time, but we just don't have it. There are very limited data coming out of Japan suggesting that that could be a way forward, but there's clearly, I hope somebody will do a study demonstrating that.
And before you, Steve, can you repeat the lab again? People are asking in the renal patients when you can't use CTX?
You can use TRAP 5B.
TRAP.
Hi, Steve Harris, University of California, San Francisco. Thank you, Bente. That was a lovely presentation. Just a question, speculation really about clinical implication. If you are stopping DMAP and switching over to ZOL, you were demonstrating that there was a decrease in bone density nonetheless, relatively modest, but there was a decrease. What do you think the implications are for prevention of multiple vertebral fractures? Because that's the dreaded outcome upon discontinuation of therapy.
Well, personally, I think that the most important thing for vertebral fractures is bone turnover, more than actually loss of bone mass. That is probably more a determinant of non-vertebral fractures. So I think the most important thing is to control the increase in CTX if you want to prevent vertebral fractures.
So I'm assuming you've not seen multiple vertebral fractures in that small cohort of patients.
Actually, not in the clinic. In the clinical experience, we didn't see. In our study, there were two in the delayed group, 2 vertebral fractures. So it is a real thing.
And then part of that is we're going to want to know as clinicians, is it a change in CTX? Is it a level of CTX? And we could talk about that later, but in the real world, that's where, you know, people that don't order a lot of markers like I don't yet are really going to want to know those numbers. Over here, can you introduce yourself, please?
Sure, Joe Lane from New York. We are doing that trial of combined drugs. We'll get that out pretty soon. Do you think we're starting too late? Do you think we should be, you know, your tartrate studies show that it starts rising a little bit earlier. So when you make up your mind, you're going to take them off the denosumab, maybe you should start at 3 months or 4 months rather than wait to that 6-month period and call that baseline. Do you think?
I think it's an excellent suggestion. I hope somebody will do that trial. We're doing another trial and we haven't included that. We have other variants included, but not that. But that could be a good way.
We have time for 2 more quick questions. Go ahead at the mic.
Hi, Adrian Michael, rheumatologist from Southern New Mexico. Thank you for the lecture. This is probably the biggest question I have when I'm treating patients. And based on some of your reduction data, do you think that maybe we might be moving towards treating this disease like we do some other things with treatment doses and then maintenance doses once we get them to goal? Maybe not, because I'm like, hey, once you're on Prolia, it's a lifelong. But seeing some of that, it's like, you know, could we use less? And is there a maintenance dose that we could use? I just want to know your thoughts on that.
No, that could be. And I'm looking forward to that continuation of the Alia Khan study on the reduced dose. But I mean, we have to take the whole experience of the patients into account. And if they have to come in many times for, you know, reducing DMAP, and then in the end, we still need to treat them with bisphosphonates, we might go for bisphosphonates right away. So we just need to learn more. But in principle, I agree. When we're thinking about osteoporosis treatment in general, including anabolic and everything, I think we should start building up bone and restoring bone architecture. And once we reach an acceptable level, and Mike will talk about that tomorrow, I'm sure, then we can find other ways. And that maybe when you're there and you're out of the rebound overflow resorption, might be raloxifene, it might be like weaker bisphosphonates, it might be different things.
So the last remote question kind of combines a lot of them. It has to do with the ZOL every 6 months if we have to or want to transition, and markers. How do we get those paid for in the US? So the part of that you can answer given.
Yeah, I don't know how you can get paid for the markers. I think So the clinical experience showed that there were clearly more patients that fulfilled the CTX criteria at 6 months compared to 3 months. But nevertheless, the ones that also needed treatment after 3 months are probably the ones that will lose the most if you only give them twice. So I think I hope it's something that can continue to be a discussion also about reimbursement of the markers, because it is not a huge group of patients, but it could make a difference for them.
All right, well, thank you so much. We're going to transition to the next session.